Hello, I'm Dr. William Berger, owner and founder of Northeast Medical Practice. We are a concierge-style internal medicine, weight management, and aesthetics practice located in Great Neck, New York on Long Island. And tonight we're going to be recording another episode of the Longevity MD podcast. This evening I am fortunate to have joining me Dr. Jay Dubowsky. I've known Dr. Dubowsky for some time, since when I was working at Mount Sinai. He's a wonderful colleague and very kind to give his time this evening so that we can discuss lipoprotein little a. So welcome, Dr. Dubowsky.
Thank you, Dr. Berger.
So by way of introduction, so that you all out there know, Dr. Dubowsky has been in practice as a cardiologist for over 20 years. He earned his medical degree from SUNY Downstate Medical Center and then went on to complete his residency in internal medicine at Bellevue Hospital in Manhattan. He then went to the Long Island Jewish Medical Center for his fellowship in cardiology, and he was chief fellow in his final year of that training. And to complete his training, he moved on to New York Presbyterian, the Weill Cornell Medical Center in Manhattan, where he completed a second fellowship in nuclear cardiology. So therefore, he's boarded in internal medicine, clinical cardiology, and nuclear cardiology. Lots and lots of time in training. So he has expertise in all aspects of clinical cardiology, including the diagnosis of coronary artery disease, cardiovascular risk stratification, which is going to be very relevant to what we're talking about today, of course, and non-invasive cardiology. So again, welcome, Dr. Dubowsky.
Thank you.
So I wanted to talk about lipoprotein little a today. It's becoming a little bit better known both in the public press and a little bit more commonly talked about in internal medicine circles, but not nearly as much as I think it ought to be. So I wondered if you could maybe start us off by giving us a little bit of basic information about what lipoprotein little a, its structure, and how that relates to its use as a risk factor for atherosclerotic cardiovascular disease.
Of course, thank you. So we've known about lipoprotein A for many years, probably more than 30 years, but it really hasn't played a significant role in our assessment of cardiovascular risk until recently, probably the last 10 or 15 years. In the past, we mostly concentrated on LDL cholesterol, which is the primary risk factor, and remains a primary target of cholesterol treatment and lowering. Now, lipoprotein A became much more apparent and even more important about 20 years ago when studies were done that documented that patients with lipoprotein A were at a much higher risk of having cardiovascular events than their age-matched people with similar risk factors. And lipoprotein A is a protein, like the name suggests, and it has a variable structure depending on the number of Kringle 4 components. And you can have anywhere between 1 and up to 40 Kringle components. These are actually called Kringle number 4, type 2, or K42s. And the size and shape of the lipoprotein A is very variable, even in the same patient. It's been very challenging to standardize the measurement of lipoprotein A. There are currently 2 different tests for it that measure 2 entirely different units. That's kind of the basics.
Okay. So if folks out there are wondering about those kringles, they're particular folds of the proteins that apparently look like a Danish pastry called a kringle. So that's where that comes from. But that variability in its size, depending on how many kringle repeats there are, makes that measurement something of an issue in terms of whether we're looking at concentration or we're looking at essentially the number of particles as a molar concentration.
Correct. So there are 2 ways to report lipoprotein A levels from the laboratory. One is in nanomoles per liter, and the other is in milligrams per deciliter. Nanomoles per liter is probably a better way to measure, unfortunately, there are no agreed upon conversions between the two different measures. The reason that the nanomoles per liter may be beneficial is because it's more sensitive or more able to determine the variable size of the lipoprotein A based on the number of Kringle components. But whatever the lab is that your insurance takes will probably determine how it is measured. And the other aspect is that the current guidelines, such that we have them, really don't recommend repeat determination. So it's usually a once in a lifetime assessment, except in certain circumstances.
Right. So although it does tend to go up a little bit during menopause, for example, you wouldn't recommend that, for example, female patients who had the test performed earlier in life repeat it once they're in menopause. Is that right?
The ideal determination or ideal assessment is still up for grabs a little bit. There are no what's called class 1 recommendations that everyone agrees on. Most people, most journals and most societies believe that lipoprotein A should be measured at least once in someone's life, most likely in late teens or early 20s, although it can be measured at any point in our current population. Once we've measured everyone now, we can start measuring it early on. Most people believe that lipoprotein A is a genetic risk factor, that there are not a lot of changes in the level as our life moves on, although you did mention some changes as people move into menopause, as women move into menopause. But the idea is to measure it once in a lifetime, and if it's in a normal or low risk range, then it probably does not need to be measured again. But if it's in a moderate or high risk range, then it might be remeasured and therapy can be addressed.
Right. And one question I often get from my patients is, can they change this? Can they lower their lipoprotein little a level through lifestyle interventions, diet, exercise, and so forth? And so then, of course, we need to discuss the largely genetic driver of this, and maybe you can speak to that a little bit.
Sure. So, as you said, lipoprotein A is largely genetically based. It is inherited from your parents and grandparents. It is dominant in its inheritance. And when somebody is found to have a high lipoprotein A, we usually recommend what's called cascade testing, meaning that everybody who's genetically related should be tested. So if it's a 50 or 60-year-old, they may still have parents who are around, and they can be tested because it can still modify risk. And certainly children and grandchildren should be tested. And ultimately the hope is that this is something that may factor down into the pediatric group, where part of the pre-high school assessment might include lipoprotein A assessment, because the duration of exposure to high lipoprotein A is a lot of where the risk is located. So the thought is that if we can improve lifestyle and other risk factors, we can reduce the negative side effects of high lipoprotein A levels.
Right, and I know that the European guidelines actually do recommend in pediatric patients if there's a strong family history of ASCVD.
Correct. So we're starting to identify people at an even younger age, so that we can identify people at the highest risk of coronary or ASCVD risk, and that we can start lifestyle modification early on, which could be things like avoidance of smoking, diet and exercise, maintenance of a healthy weight, and so forth.
Right, right. So people may, if they're not that familiar with the subject, be wondering how does the protein actually cause, because we do believe that there is actually a causal link between lipoprotein little a and atherosclerosis, but also inflammation and possibly increased risk for thrombosis. And
Correct.
The structure of the protein kind of drives those other aspects of its pathology.
So lipoprotein A is still relatively new to our studies. In fact, we don't even have medications that are officially approved to treat lipoprotein A. So we're still in the early stages of understanding this protein. We do know that it does a couple of different things. We know that it is atherogenic, meaning it causes blockages to develop in the heart arteries, and those are largely cholesterol-based. That cholesterol gets into the wall of the coronary artery and other arteries. It becomes oxidized and becomes a form of bad cholesterol that builds up slowly in the arteries. We also know that it is the lipoprotein A, based on its structure, is thrombogenic, meaning it increases the risk of having blood clots in the body. And we know that coronary artery disease is not necessarily a blood clot problem, but heart attacks are, because most myocardial infarctions or heart attacks happen when there is an imbalance of coagulation. Prothrombotic components are higher, and that creates a blood clot that causes the heart attack. And the other aspects of the lipoprotein A are that it can bind to platelet glycoproteins, and then this affects the uptake of LDL into the wall of the heart arteries.
Right, and lipoprotein little a also carries an awful lot of oxidized phospholipids, I believe, as
Correct,
well,
yes.
which would contribute to a lot of the inflammation in the subendothelial space of the artery.
Correct. To go back to your question about starting and when did we learn about it, is that the early studies that looked at LDL cholesterol and risk were the ones that really were an early identifier of lipoprotein A. And at that point, it was more of a bystander. They measured it, they knew it was there, but none of the early studies really treated it. But they were able to find that people who had reductions in their LDL, or bad cholesterol, had reduced risk, but the people who had elevated lipoprotein A levels had much higher risk, even if their LDL cholesterol was controlled.
Right, and that was later borne out, and we'll get to those studies with regard to PCSK9 inhibitors and so forth
Correct.
that demonstrate all of that. But not only for ASCVD, but there's also, it's a little less clear, I think, in terms of CVA, stroke risk. But I do believe that the Copenhagen City Heart Study did show a relatively strong association between the level of lipoprotein little a and stroke risk. But of course, there are various types of strokes. They're not all due to thrombosis. So
correct. So there are a couple of aspects to lipoprotein A, and again, we're really in the infancy of studying lipoprotein A. We do know that it increases the risk of what's called MACE, M-A-C-E, major adverse cardiovascular events, which is heart attacks, strokes, and death. We also know that it can increase peripheral arterial disease, also called PAD, and it's also been associated with aortic valve calcification, and there are now ongoing studies if reducing LPA can actually prevent aortic stenosis. Now, many of your patients may already have heard of aortic valve replacement or even the TAVR valve, and both of those are done because of calcific aortic stenosis, and certainly TAVR is a much advanced way to treat that rather than open chest surgery, but certainly prevention would make a lot more sense if we can avoid doing the surgery at all.
And I believe that lipoprotein little a, or the LPA gene, that's really the only known genetic driver, or at least monogenic driver, for calcific aortic valve disease. Is that correct?
That is correct, yes.
Okay, so yeah, so all four issues, the ASCVD, the stroke, aortic valve disease, and peripheral arterial disease, all linked with lipoprotein little a. Now, you had alluded to some of the guidelines, which are all in flux, but we've talked a little bit about the Europeans. They recommend measuring once in a lifetime, and also in younger folks if there's a strong family history. Here in the States, more when you believe there's high risk and or there's been an event, but you would lean toward perhaps how the Europeans, the Canadians are approaching it and advise to test it in a lifetime, which I think would be quite reasonable.
Within the field of cardiology, the Europeans tend to lead the United States by 5 to 10 years in a lot of our guidelines, not only in blood pressure control, but cholesterol control, glucose control, and the management of lipoprotein A, not only the diagnosis, but the treatment.
Okay, so we're all in agreement there, I would say.
I do agree with the idea that we should be testing everyone at least once. And based on their levels, since we know that there is not a lot of change over a lifetime, if somebody is considered low risk, and that would be less than 70 milligrams per deciliter, then they probably don't need to be tested again. The medium risk people are between 70 and 120 or 125, and then the patients at the higher risk are over 125, and I've personally seen levels as high as 500. And there's a linear relationship between risk and exposure to lipoprotein A. So the higher the level, the more the risk. So even at a low level, there is some risk, and the hope is that we can reduce the risk of events based on adjustment in risk factors. And that's where the European guidelines are really ahead of us.
Mm-hmm, mm-hmm. Well, so that leads into the next part of the discussion that I wanted to open, which is, okay, so we have a patient who may have lipoprotein A in the moderate range, say between 70 and 120, or perhaps it's over 120. Let's take the 70 to 120 case. How do you like to use the pool cohort equations that we often use in the United States, and then add in the lipoprotein little a elevation as an additional risk factor? How do you like to approach it in these sorts of patients?
So part of the difficulty we have is that the guidelines that we currently have are really not very effective in adjusting risk based on the presence or absence of lipoprotein A. The guidelines do suggest that if you have a normal lipoprotein A level, that we can essentially use our current pooled risk factor analysis. When patients have moderate or high levels of lipoprotein A, there's little guidance in terms of their recommendations for therapy and management. Now, once a person has reached a moderate risk of cardiovascular events or ASCVD in the next 10 years, and that risk is 7% or more, most people agree that there should be significant reductions in LDL cholesterol through lifestyle management and also through medications and therapy to lower LDL cholesterol. Now, once a patient has a high or very high lipoprotein A, we're kind of going off book in terms of lipoprotein A guidelines, because there are no treatment guidelines for lipoprotein A. But we could certainly at this point, if you're comfortable, discuss some of the medications that can help control lipoprotein A and levels.
Absolutely, that's where I'd like to go with the conversation, and when we might move from using somewhat more common cholesterol-lowering agents like statins, ezetimibe, bempedoic acid, things of this nature, or moving on to something like a PCSK9 inhibitor.
So our standard of therapy is still statins. Lowering statins by 50 to 60% is really in the guidelines, and the recommendations for LDL lowering is a little bit different between the American papers and the European papers. Now, studies have shown that if you lower the LDL cholesterol maximally, depending on your individual risk, you can reduce your risk of a cardiovascular event, notwithstanding lipoprotein A. Now, the guidelines that I follow are more of the European Society of Cardiology guidelines that suggest that if a patient is medium risk, between 7 and 15 or 16%, the LDL cholesterol should be brought down below 100 and potentially below 70. The guidelines also suggest that in a patient with diabetes, which is an additional risk for coronary disease, we should lower the LDL below 70. And if a patient is very high risk or has already had a vascular or cardiovascular event, the LDL should be below 55. Now, there are studies that show that even in infancy, the amount of LDL in our body is probably between 5 and 10 milligrams per deciliter. And there are studies that show that LDL as low as 30 are safe and effective, particularly in secondary prevention in patients that have had severe coronary artery disease or multiple stents. Now, the standard of care for that is statin therapy or HMG-CoA reductase therapy, and the statins will lower LDL cholesterol aggressively. There's a low, a medium, and a high intensity statin. Low intensity statins, for example, are Pravachol. Medium intensity statins are simvastatin, and the high intensity statins are atorvastatin and rosuvastatin. Now, there are other medicines that we use in conjunction. Niacin can lower lipoprotein A, even as much as 20%, but the problem is it's never been shown to have or recent studies have shown that it does not have a beneficial effect on cardiovascular events and may actually increase the risk of stroke, as well as its intolerable side effects, which are actually very common in patients who take the prescription form. The over-the-counter forms of niacin are probably not beneficial at all.
Yes, but the patients often really complain of flushing and so forth that goes with
Yes.
the higher dose niacin.
The other advantage of niacin is that it will raise HDL levels, but those also have not been borne out to show a marked reduction in risk, even though the HDL levels do increase.
Right. So, if I could just interject on the HDL,
Yeah.
because that's of interest to a lot of our patients who still like to talk about the fact that, well, my HDL
The ratio, yes.
is in the normal range, so maybe I shouldn't worry about my LDL cholesterol so much. But perhaps it's more about the function of the HDL and how it works in reverse cholesterol transport and things like that.
Yes, correct. One of the problems we have is that many people do have high HDL levels that are protective, but some people also have high HDL levels and the HDL is not effective at reducing risk. And it might be in this case where calcium score test would be beneficial because it creates an individualized risk for coronary events, as opposed to comparing people to what's called a pooled analysis, where we're comparing an individual patient to a group of 10,000 people who share similar characteristics and assuming that their events would be the same as an individual patient.
Right, and I would like to get into a little bit of a discussion about imaging and other modalities in a moment.
Of course.
But for
Other
PCSK9s, yeah.
So other medicines that can be beneficial are bempedoic acid, which lowers LDL but does not lower lipoprotein A, and Zetia similarly does not lower lipoprotein A to any significant extent. But by lowering LDL, we can reduce overall risk. Now, the two most important medications that we have studied that lower lipoprotein A are the PCSK9 inhibitors. Now, these are antibodies to the PCSK9 protein. And the way the PCSK9 protein works in the body is that PCSK9 binds to the LDL receptor on the liver, and it allows the liver to absorb the LDL receptor, and this creates an effect that there's more LDL available in the blood. Now, PCSK9 inhibitors are an antibody. They bind directly to the PCSK9 protein. They reduce the amount of the protein in the body, and as a result, they can reduce LDL cholesterol. Now, the current studies that we've looked at, and the studies were Fourier and Odyssey outcomes, and both of these studies, one looked at evocalimab and the other at alirocumab, and you'll notice that both end in MAB, which is an antibody indicator. So anything ending in MAB tends to be an antibody medication. but both of these target the PCSK9 protein, because the PCSK9 protein reduces LDL receptors and increases blood LDL. And by using this antibody, we block or take the PCSK9 protein out of the body, allow the body to absorb it, and that allows the body to naturally reduce the amount of LDL in the blood.
And it was interesting, the studies that were done to originally suss this out in folks who were genetic variants, in the sense that they lacked PCSK9, or they were heterozygous, they only had one copy for it, and would have very low LDL cholesterol levels.
Correct.
And not tend to have the things that we know that an elevated LDL can cause.
Correct. So thankfully those patients were available and we were able to study them, and they've given us the ability to target this protein. Now, the COVID vaccines, to use an analogy, are small interfering RNA, and two of the COVID vaccines worked on a different protocol, but also affected PCSK9. Now, there's a medication now called Leqvio, or inclisiran, and that's the other medication that we use that both lowers LDL dramatically and also lowers lipoprotein A. Now, Leqvio or inclisiran is given as a small interfering RNA, and what it does is it blocks a certain protein's production, and that protein is necessary for the development of PCSK9. So by blocking that protein, we reduce the amount of PCSK9 and also reduce the amount of LDL in the blood. And both the antibody medications and this small interfering RNA also have both been demonstrated to reduce lipoprotein A by as much as 15 to 20%. Now, that's not why they were invented. The medications were invented to lower LDL, and as an added benefit, they lower lipoprotein A as well.
Right. So I want to talk about those two trials just a little bit, Fourier and,
Sure.
and Odyssey outcomes, to try to maybe tease apart whether the reduction in risk is due to LDL cholesterol lowering with these medications, from lowering of the lipoprotein A itself, because there does seem to be a little bit of debate about how much of the decrease in risk is from lowering LDL cholesterol and how much from lowering LP little a at the same time. It seems to be clear from Odyssey that it's independent of the LDL cholesterol reduction, but maybe you could talk to that a little bit.
Well, you've hit to the chase of this, is that it's not very clear which is the stronger reducer in risk, whether it's the LDL cholesterol reduction or if it's the lipoprotein A reduction in the reviews of the studies. Now, both studies have demonstrated dramatic reductions in LDL. Both studies also demonstrated modest reductions, at best, in lipoprotein A levels of 15 to 20%, but not in all patients. Some patients responded better than others. Some patients had lipoprotein A levels that were not affected, and some had lipoprotein A levels that were reduced by as much as 50 to 60%. And as I said before, the exposure to lipoprotein A, length of exposure is part of the problem. It's also a linear relationship, so the lower the lipoprotein A goes, theoretically the less risk that there is. Now, these studies are done on top of a baseline medication of statin therapy, which reduces the overall effect of the PCSK9 inhibitor. Now, we know that statin medications have reduced cardiovascular events rather dramatically, but Fourier, which studied evolocumab, showed a reduction of 20% of cardiovascular events or adverse cardiovascular events, heart attack, stroke, and death. Unfortunately, since we're further reducing risk, we actually need to treat 74 patients over 2 years to prevent one event. So the overall benefit in this is a little confusing, because if we're treating 74 patients over 2 years to reduce or eliminate one event, that's a lot of medicine, a lot of money, and a lot of exposure to reduce one event. But other events have also been documented to be reduced.
Right, and these are all still on branded, on-patent medications, and quite expensive. And I know that insurance coverage for both evolocumab and alirocumab can be an issue for patients.
Correct. And honestly, both medications are only available for patients with elevated LDL. Lipoprotein A elevation is not an indication, and if there's a patient who has their LDL controlled on statin, these new medications may not be authorized by insurance, and there is an appeals process that we can go through to try to explain to the insurance company why we feel that lipoprotein A reduction is also required, but it's somewhat of an uphill battle.
Okay, and you had mentioned coronary artery calcium score and so forth. I'm wondering if you could talk to how you might utilize CAC, as we call it, or CT angiogram of the coronary arteries,
Sure.
Ultrasound of the intima of the carotid arteries, things of this nature.
Okay. So carotid intimal medial thickening as a diagnostic tool is wonderful. It's non-invasive, it's inexpensive, it doesn't require any patient preparation. It can be done very quickly in 5 or 10 minutes. Unfortunately, carotid intimal medial thickening did not meet the criteria for primary screening. So while it is a useful adjunct in patients who are at risk for coronary disease, and I personally find that documentation of cholesterol buildup in the carotid arteries, particularly the internal carotid artery, is an added risk factor for heart disease and other cardiovascular events. It doesn't meet the criteria for primary prevention. Now, traditionally we have used stress testing as a means of determining who's at high risk for cardiovascular events. The problem is stress testing was created in a time where cardiovascular events were primarily severe coronary artery disease, and stress testing was designed to determine patients who had blockages in their arteries more than 70%. And that percentage was based on the fact that patients who have lesser blockages, even found at the time of a coronary angiogram or catheterization, do not receive stents, because stents have only been shown to reduce cardiac events when blockages are more than 70%. In fact, coronary angiogram and stenting has never been shown to reduce heart attack. It reduces angina. It's only in the setting of acute coronary syndrome or a heart attack that it's been shown to reduce morbidity and mortality. Now, calcium score, or CAC, is probably the best new way that we have of determining coronary risk for patients who are at low risk, because a patient who's at moderate or high risk probably would have other testing done. Coronary calcium score is a test whereby we measure how much cholesterol is in the coronary arteries. Now, coronary calcium is actually what's measured, and coronary calcium is a marker.
I'll just interrupt for one second. I'm sorry. It looked like there was maybe a connection problem for a moment. I can cut out what we're saying right now, so maybe if you want to just go back a moment to the beginning of what you were saying.
Sure. So coronary calcium is a marker for coronary cholesterol. Unfortunately, cholesterol, even in the arteries in the heart, is soft. It has the consistency of toothpaste, so it doesn't show up on a CAT scan or an MRI. However, the body also deposits calcium in the coronary artery in the same location where there's coronary cholesterol, so we can use coronary calcium as a marker. Now, there was a study that was done called the Power of Zero that said that in a patient who has zero calcium and presumably zero cholesterol has an extremely low risk of cardiac events. And most people have extrapolated that to indicate that anyone with a calcium score less than 10 is probably at a similarly very low risk of cardiac events. In a calcium score between between 10 and 100, patients are at low risk of having cardiac events. A calcium score between 100 and 300 at moderate risk, and then above 300, patients are at increasing risk of cardiac events. Now, the reality is that patients who have coronary calciums over 300 are not at an immediate risk of cardiac events. And I've seen patients with calcium scores over 5,000, while seemingly very high, do not have significant obstructive coronary artery disease. And that's probably a discussion for a different time, but it gives us a gradation and an estimation that may be more personal and more accurate rather than what's called a pooled analysis, where an individual's risks are compared to a group and try to extrapolate an individual risk based on a large group of people.
Yes, yes, and I'm often asked by patients as well, although, like you said, maybe it's another whole discussion, the differences between the coronary artery calcium score and CTA of the coronaries and so forth. But the softer plaque, is there a relationship between elevated lipoprotein A levels and there being more of the softer plaque, or that there isn't as much of a fibrin kind of cap to the plaque, things like this?
That's actually the big mystery of cardiology in the current generation, that calcified plaque, heavily calcified plaque, doesn't rupture and doesn't cause heart attacks. It's only the soft plaque with small speckled calcium that's the highest risk for myocardial infarction. So that's our big mystery, is trying to identify those patients who are at the highest risk, and those patients actually have little or no calcium in their arteries. And that's where carotid intimal medial thickening may be an advantage, because if we see soft plaque in the carotid arteries, we assume that that same soft plaque is in all of the body, and particularly in the cardiac arteries, and those patients can be treated more aggressively.
Okay, and do you probably would do an echocardiogram in most patients regardless, but in terms of looking at the velocity across the aortic valve, any stenosis calcification, does that play into your thought process as well?
Aortic stenosis, particularly calcific aortic stenosis, is a long-term process, and only patients with at least moderate aortic stenosis are really considered for the ongoing studies of lipoprotein A reduction for patients with calcific aortic stenosis. We see aortic sclerosis as a normal finding in many people, and when aortic sclerosis progresses to mild and then moderate and eventually severe stenosis, it's a difficult progression, because patients will often stay with aortic sclerosis for many, many years and never progress. There are patients who have either mild or moderate aortic stenosis, which is usually calcific, and may also never progress. And there are a few patients who progress rapidly from very mild to very severe stenosis, which becomes symptomatic, and those patients are the ones who were referred for surgery. There are only the assessment of lipoprotein A and aortic sclerosis and aortic stenosis is really in its infancy, and there are only level 2 and level 3 trials right now for lowering lipoprotein A in those patients.
And thank you for that. And lastly, on the medication front, a very old medication that used to be used much more often in primary prevention of cardiovascular events, and that's aspirin.
Yes.
So aspirin use in patients with elevated lipoprotein a.
So aspirin has gotten a bad rap in recent years because there was a study done that showed that younger people, particularly women, were at a higher risk of having GI bleeding, and that there were more GI bleeds than there were cardiac events protected or prevented. Recent assessment has shown that patients who are at high risk, either because of elevated LDL or elevated lipoprotein A, should probably be on a baby aspirin daily, because not only does it reduce our documented risk of cardiovascular events, but it also acts as an antithrombotic, and we already discussed that lipoprotein A has prothrombotic activity, so an aspirin a day may be beneficial in reducing the risk of thrombosis related to lipoprotein A.
Okay, wonderful. And you also mentioned genetic testing. If there's a proband, somebody who has been found to have an elevated lipoprotein little a, to pursue genetic testing of other family members. Do you typically send folks to medical genetics or to lipidology? Who often performs that testing?
So generally, if a patient is found to have a high lipoprotein A, I generally don't send them on to genetic testing. If they have extremely high LDL cholesterol, usually greater than 190, they go on to medical genetics to check for familial hypercholesterolemia, or FH. People who have LDLs less than that, especially if they have a strong family history of premature coronary disease, meaning men less than 45 and women less than 55, those people should be tested early rather than late. And I'm now incorporating lipoprotein A testing in all my patients to assess for cardiovascular risk, and also risk stratifying them based on low, moderate, and high levels of lipoprotein A. Now, since we've discussed that PCSK9 inhibitors are only available to patients with high LDL, and if they get to goal on statin therapy, probably won't be approved for PCSK9 inhibitors. The use of PCSK9 inhibitors to lower LPA is of questionable use right now, and it's only in those patients who are poorly tolerant of statins, intolerant of statins, or have another contraindication such as an allergy or elevated liver function test who can get the PCSK9 inhibitors. Now, insurance can vary, and insurance coverage can vary, and Medicare patients are generally at an easier level of getting these advanced medications approved for them. I hope that answers the question.
It does. It's always an ongoing issue, insurance coverage
Yes.
for medications for our patients.
Now, I'm going to interject one thing, that the PCSK9 inhibitors are great medicines, and they're very safe, and they're very effective. The biggest side effect is injection site irritation and rare allergy. Both of the PCSK9 inhibitors are given by a pen injector every 2 weeks. The small interfering RNA, Leqvio or inclisiran, is given as a subcutaneous injection, and the advantage of that is it's given once every 6 months. Unfortunately, that can only be given in a clinic with lipidology or at an infusion clinic, which creates a little bit more of a hassle for patients, because it's not done either in a doctor's office or at home, but they have to have separate appointments with an infusion clinic.
Right. And yeah, so as you know, I've also incorporated screening lipoprotein little a in all of my patients, because I think it's really an underutilized test. Upwards of 30% of the world population has an elevated lipoprotein A.
Yes.
And if we don't look, then we don't know. So what advice would you have for patients, or perhaps even clinicians who might be listening and watching today with regard to this kind of testing?
Well, having a doctor who's particularly interested in prevention, I think, is important. Having a doctor who spends time talking to the patient, examines the patient thoroughly, and then reviews the results is going to be important, so patients understand where they are, what their blood tests mean, and what their risk is. And I think that our goal ultimately is to create an individualized risk for patients, looking not only at risk factors, both the modifiable and non-modifiable risk factors, as well as things like LDL cholesterol and lipoprotein A, and using that to come up with a composite risk, and then using standardized testing like calcium score, CAT scan of the coronary arteries, carotid intimal medial thickening testing, and advanced testing like stress testing to determine risk and then help guide patients into different therapies.
Well, thank you so much for your time this evening, Dr. Dubowsky. It's been a very enlightening conversation, and perhaps in the future we'll be able to sit down and have another about some of the other things that we weren't able to spend as much time on.
Thank you for inviting me tonight.
My pleasure. Welcome to the Longevity MD podcast, where we discuss all aspects of health optimization. This is William Berger, MD, your host. The information contained in this podcast and other media derived from it is for educational purposes only. It does not constitute the practice of medicine or any other healthcare services or the provision of medical advice or treatment. No doctor Information contained in this podcast and other media derived from it is for educational purposes only. It does not constitute the practice of medicine or any other healthcare services or the provision of medical advice or treatment. No doctor-patient relationship has been formed. Users of this information do so at their own risk. For any concerns or questions, users are directed to seek the advice of their medical professionals. The information contained in this podcast and other media derived from it is for educational purposes only. It does not constitute the practice of medicine or any other healthcare services or the provision of medical advice or treatment. No doctor-patient relationship has been formed. Users of this information do so at their own risk. For any concerns or questions, users are directed to seek the advice of their medical professionals. The song Vital Signs was written by Geddy Lee, Alex Lifeson, and Neil Peart of Rush. Performed here by Dr. William Berger. The song Vital Signs was written by Neil Peart, Geddy Lee, and Alex Lifeson of Rush. Performed here by Dr. William Berger. To learn more about Northeast Medical Practice, our health optimization clinic, To learn more about Northeast Medical Practice, our concierge-style health optimization clinic, please call our office at 516-604-3418 or visit us online at northeastmedicalpractice.com.